The next part of our panel or our conference is the panel discussion. So I'd like to welcome back all our speakers just to the front here. And in addition to that, I would like to invite three special guests who will join our panel. Dr. Trevor Pugh, who is our genetics expert, Dr. Carolyn Nissan, who is a surgical oncologist, and Dr. Howie Lim, who is a medical oncologist. If you guys can all join me here at the front. What I'd like you to notice is at the sides of each staircase, there are two microphones, and there's also volunteers that have a microphone that they can hand out. And we'll start out the portion with just asking any questions from the audience. So does anyone have any questions from our panelists?
So Paula's not here. I'm taking this class. Fine.
And we'll also get Teresa to come in to also represent the patient voice. Alrighty, so I see some questions already. Go ahead.
Hi, am I on? Can you hear me?
Yeah, go ahead,
Okay.
Maria.
My question is for Dr. Mosko. You were talking about endoscopy and its benefits of diagnosing cancer earlier. How does it play into the monitoring of patients after they've had their surgeries, their procedures, their treatment? Should it have a big role in the kind of ongoing, and what should that ongoing endoscopy care be for someone who is a survivor of gastric cancer?
So that's it. Is this on? Yeah. That's an amazing question. Thank you so much. I would say the answer is complicated, as most of them usually are. And I'm also interested in some of the thoughts from the panel. I think to me, it depends on a few things. Number one, have you had a partial gastrectomy or a total gastrectomy? So is there stomach left, and what is the risk of developing something new in the remaining stomach? And then number two is, what is your, regardless of what surgery you've had, what is your underlying risk from a genetic standpoint? Is this a sporadic cancer, meaning we don't have a gene, or is this related to a high-risk gene or a high-risk family? And then not only will I want to monitor the rest of the stomach, but I would also want to monitor some things that are also left behind, like the small intestine. So I would say, in my mind, the way I think about it is, what's the risk of the rest of the stomach? What's left over? And then how are you feeling, right? People who have had a surgery, even a total gastrectomy, and maybe have a narrowing at the surgical site called the anastomosis, those people may need endoscopy and may need some sort of intervention to help them eat better. So what's the risk and how are you feeling? So endoscopy plays a role in all of those patients. But I would say just a routine endoscopy in patients who have had an operation is not necessary, but it is necessary in certain circumstances. Did that answer your question? Okay, great.
Other questions from the audience? Okay. So at the time of registration, all of you were asked to, oh, I'm sorry. Go ahead.
So my question is for so you mentioned that there are specific tools that are able to detect, that are able to detect cancers earlier than perhaps other tools that are being used, and those are in specific locations. How does that information funnel back to, say, family doctors, the public? How do they know where to look for that?
Yeah, it doesn't, and that's a problem. Because, and someone in the audience asked me, they said, I'm going to have an endoscopy this week. How do I know that my doctor is using the best tools available? And there's no way of knowing. And so I think that, in the US, endoscopy is a business. And so everyone is advertising their program, that they have the best tools available, that they're the most up to date, that our doctors are the most famous, et cetera, and that attracts people to those programs. In Canada, which makes no sense to me, people are just thankful to have any doctor, right? And they're just, they don't always focus on what the quality is of the procedure that they're getting. The assumption is, and I hate to sound jaded, but the assumption is that all physicians are created equal. And unfortunately, like, you know, just like me as a golfer, like I'm terrible and the person next to me is better, there's a spectrum of skill. And someone who does things all the time and does things 5 days a week is usually going to be more skilled than someone who does it a half day a week or a day every other week or something. And so it's important to know who is doing your procedure, because I think and physician technique is the number one most important. And then also, are they at a center that is willing to invest in the most up-to-date equipment? And that's important too. I worked at an ambulatory clinic right when I started my practice, and I had to resign from the clinic because I didn't agree with the type of equipment that they had there, and they weren't willing to bring it like up to what I thought was the standard of care. And so I said, sorry, I will not, my name cannot be associated with this. And in fact, if you don't buy new equipment, I'm going to report you to the CPSO, because this is unacceptable and patients shouldn't have to have substandard care. So, we have a long way to go to, I'm glad you think this is funny. We have a long way to go to standardize the care that we provide. And I think AI is going to help with that, because it's going to give and I'm actually, next week I'm going to Chicago to meet with Olympus, who is the #1 manufacturer of scopes, to help them design their quality metrics for upper endoscopy so that they can build it into their system. So that after your procedure, what I think should happen is you should get a report card after the procedure. Instead of saying you're fine, right? You should get a printout that says your physician saw 100% of the lining of your stomach and there were no lesions there of concern, right? And the AI is going to support the physician in making that determination. So you're going to have a physician report and an AI report, and it's going to say they saw this, they saw this, they saw all the landmarks, they biopsied the right places. So you need a watchdog watching all physicians.
All in the field, is there anything now that can kind of stress to the government how important this would be and for programs to be put in place? Because it sounds like we're far away from that.
I mean, it is a public healthcare system. So I totally agree with everything you just said. And however, it is a public healthcare system. And, you know, how much more are you going to tax everyone? How much more are we going to... I think it's a question of how the funds are used. They're probably just ineffectively used, and they need to be used in a much better way so that we can advance in our technology. But I'm a surgeon. I live my life without technology that I want, right, on a regular basis. So I do think it's a challenge. It's a challenge getting bigger, brighter tools that definitely help and definitely improve quality. But when the hospital says, I just don't have the money, so we're stuck. Whereas in the US, yes, it's a business, but they also have the money. And I think that's where our challenge happens, right?
But that, I hear what you're saying, and yeah, I fight that fight every day too as a Canadian innovator, but that's not acceptable, right? Like, just saying, like, I live my life wanting more technology, but some of those technologies that we use are going to save the system money, right? So it's finding the things that the government should pay for that are actually going to decrease the costs overall. So having a 7th robot at your hospital like may not actually save any money and may just be like a fancy expense, but having one might like be a good investment.
Totally agree. It took me 5 years to get the SPY in our hospital. And I had to create a business plan, and I had to show how it decreased the leak rate in gastric cancer and in colon cancer. And I had to, I basically called the pharmacy and said, how expensive are antibiotics? So it took me like a good, 3 months just to gather the information of cost to do this cost analysis. I'm a busy surgeon. Like, this was a lot of work on my part, and it still took 5 years for the hospital to approve it. So all I'm saying is we can, but you need someone who is going to be perseverant and keep pushing and pushing and pushing until they bend, right? And I think it can get exhausting. So it's a lot of work. And I totally agree with you. It's unacceptable because I'm like, we could save $1 million. And I showed them the cost analysis of a leak, right? And if we reduce our leak rate, we'll do better. But I think the Canadian healthcare system in general needs to stop looking at budgets in a silo, because unfortunately, the OR budget is not the ward budget, is not the ER budget, and so for the OR, we increased the cost. And it doesn't see how by decreasing the cost on the ward, you're benefiting overall in the hospital. So I think they're starting to realize that you can't keep doing budgets in silos.
So is this working? Okay. So I think from an organizational perspective, patient organization, I think one of the things that we can do is try to collect the information of the centers of excellence, so that we can at least provide that to patients readily on our website, which is one of the things that we are actually working on to make our website much more, up to date, much more accessible, so that patients can quickly go somewhere and say, okay, this is a site that I can go to that lists the centers of excellence, within Canada for our patients in Canada. And we always also try to say, these are the centers of excellence, let's say in the US, because we get asked that, and we also get asked also in Europe. But, and we promise this, it's one of the things we're working on, but as volunteers, it took us a little bit longer, but I think really, and it's also part of our advocacy work, because that's what patients want to know is, where can I go to get the best care?
Where they have it.
Yeah, so if it will take, the work that we put into it to, look up and talk to the doctors, which we work with all these doctors across Canada, and provide that on our sites, provide that as part of, the next, maybe a webinar, things like that. So from a patient advocacy perspective, I think knowledge is always better, and so that's one of the big things that we are working on to update what is accessible to patients.
Well, I'm really struck by the parallels between surgery and endoscopy with genetics. It's exactly the same. Technology is like raced ahead, and you may have had especially a test for hereditary cancer variant even 10 or 15 years ago, told it was not familial, but technology has advanced so far, and there's so many new genes that can be tested. In the past, I might have just searched for one little piece of one gene. Now you can literally sequence every gene. So there's really a need for genetic technologies to be keeping a pace as well, and what might have been negative even 5 years ago might not be negative on conventional tests. So access to those tests, making sure that funding keeps up with them, is totally important, because it's amazing what you can do now versus even a few years ago.
Very cool conversation. So it sounds like technology is outpacing our healthcare system at this moment, and it sounds like we need more research to know what is the most cost-effective strategies across the board. Thank you. Any other questions from the audience? Okay, Rebecca, go ahead.
Hello. Oh, is this? Okay. Oh, that's very loud. Hi, beautiful minds, great panel of the most smart people I've ever spoken to in my life. And I think I speak on behalf of a lot of people in the room here. Once you kind of get that first diagnosis as a family member, as a familial system, it really changes your life. And as you go through treatment and then maybe recurrence and maybe palliative, like all those stages, I just want to ask all the great minds at the front, what's your best one-liner piece of advice for any stage of the journey? Because I think, you know, from the beginning to the end, it changes as we go through. And I think I've heard such great pieces of advice, and I just kind of want to share that with the room with such smart people on the panel.
So I even personally had, recently a family member die of metastatic pancreatic cancer. He was 49 years old. It was very hard as the doctor in the family to not to be able to help, but I did a lot of things. And I think the one thing I do tell patients, number one, positive manifestation absolutely makes a difference. I have seen it over and over and over again. Patients that are positive and have a positive outlook and want to fight it actually do. It's kind of scary how connected our mind is to our body. So unfortunately, you can't control the cancer. The cancer's there. There's nothing you could do about it. You can't actually control that. So worrying about it doesn't change anything. It's there. But what you can control is your mindset. And so when you work on that, and that's probably the biggest job you'll ever have to do because it's so hard to do. But if you take the time and you really work on your mindset, you'd be surprised of how, like, all of a sudden these doors start to open and positive things start to happen. And that positive energy that you give yourself actually can make a difference. Like, I've seen so many patients that should have passed a lot sooner than they did, and they didn't because of their positive energy. And then I've had other patients that are so early stage that definitely shouldn't have had any issues, but because of the riddled anxiety or fear, just don't do well no matter what I try. So I think it is really that positive energy manifestation. I'm not saying it's easier said than done, but I'm saying how impactful it can actually be.
So I'm a medical oncologist, and probably I see or touch patients in the majority of their journey, from localized disease to metastatic disease to transition to palliative care, and obviously really appreciate you. I will say that I talk to my patients about controlling the controllable and hoping for the best, but also preparing for the worst. Because I think, we do want to make sure that we're doing the best we can up front, no matter what stage the disease is diagnosed in. Meaning, if it's localized, let's give the best treatment we can. If it's metastatic, let's give the best treatment that we can. But also understanding that some things are outside of our control. And no matter what, I think we have to continue living our lives the best way we can as we go through all of these different steps, which are so unpredictable. And what I've found with my patients is that the needs are so different for different patients. I will often have a different conversation depending on the need of my patient. And I think having just one statement that kind of fits all is really, really impossible, at least for a medical oncologist. I kind of wish, though, that there was more psychosocial support for patients. I also wish that there were better supports for younger patients, because we're forever seeing much younger patients with this disease.
I'll try to wrap it up. The one sentence I would take from what you said, and what I would say is, don't just exist, focus on living. It's a little bit different from what my two colleagues just said, because living also includes negative emotions, also includes conflict. It also includes the ability to say, F it all, I can't do this anymore. It involves the ability to be honest and open about how you're feeling. So I might want to add, don't just exist, live, and don't withdraw. That's maybe the most general advice that I would give on the basis of your excellent question. And I know how much you are living and fighting, and I'm very grateful that you're here. Thank you.
Thank you. We do also have 2 patients at different stages of their journey. So Samantha and Teresa, are there any words of wisdom that you'd like to share with people regardless of their journey?
So I'll say something, it's something that I've kind of lived by. For those of you that don't know, I've been on the cancer journey for 23 years. And because of my genetic situation, I have dealt with 13 different types of cancer. So what I say to myself every day is 1 minute at a time, and accept that minute as a miracle, because it's never going to come back. I really try to do that, even in my worst days, in my most angering days, in my saddest days. At the end of the day, I kind of just look at it and say, you know what? I did have some good moments there. And people ask me how I'm still here. And sometimes I say, I think I'm just really, really so headstrong and sometimes really angry. I just don't want this to get me down, that I just keep going. And the only other thing I can say is advocate for yourself in whatever situation that you are. But truly 1 minute at a time. And I think that goes for everybody, because we just don't know what is going to happen to us in the next 30 seconds. So I just take it 1 minute at a time. We always say 1 day at a time. Sometimes I say, sometimes it's 1 hour, and sometimes it's 1 minute.
Thank you. And when you all registered, we did ask you to submit some questions. Of course, I have 6 pages of questions here. I won't be able to go through all of them, but I will try to make sure to kind of code them, and then if a subsequent lecture is needed, I'll try to address those questions later. We also have a secondary panel. But since we have our genetics expert here, one question that came up a lot was hereditary syndromes. So CDH1, Lynch, BRCA, carries a high risk of gastric cancer. What does surveillance and risk reduction look like for patients that have a known genetic disease?
Yeah, and this fits so nicely with what I wanted to reply to the previous question, which is how important it is to participate in research. I mean, your blood or tissue sample might hold the key. You never know. It's usually that one sample gives you that blinding insight that unlocks everything. Our approach that we're running in Canada is the CHARM consortium, where we're trying to integrate blood-based cell-free DNA testing, which several other groups mentioned, and integrate that as part of surveillance as well alongside standard of care. So the way that study is working is we're moving up the surveillance to be more frequent, so every 4 months instead of an annual surveillance visit, but also trying to design a blood test that can cover multiple different cancer types rather than one test, one cancer, one test that can overarch and not just be the test that stands alone, but something that's more accessible, that can be done more frequently, and then would trigger an endoscopy or whatever follow-up test, colonoscopy, is needed depending on what we can see in the blood. So that's really where the research, especially for hereditary cancer, is sitting now, increasing access to comprehensive germline testing to know your risk. But then once you know your risk, that risk doesn't go away, and then conducting research to do more frequent and more precise surveillance using blood.
Thank you. And then there's a recurrent question about nutrition and diet. And Carmen, I was wondering if you can weigh in on some of these. So there's a question about if the ketogenic diet works. There's also a question about the association of sugar and cancer. Is there anything that you can comment on?
Oh, we could talk about this topic for hours and days. Specific to the ketogenic diet, unfortunately, there's a lot of different information out there, but I think the truth of it is that, once you have been diagnosed with cancer, you have cancer, and there's no magical diet that is going to fix that. When you are talking with individuals like patients who are already struggling with eating, piling on top of that restrictive diets isn't going to help them. It will probably just make things worse. And so, you know, like the whole like sugar feeding cancer, how I phrase it to patients is that your body is always going to, you know, search for ways for survival. You not giving it sugars, not giving it fats, not giving it, you know, anything isn't going to change the fact that the cancer will grow. Your body will just simply take from other places where it stores the nutrients that your body needs to continue surviving. So, for example, if you don't eat enough protein in your diet, for example, your body will take from your muscle and make that a way for it to gain the, you know, the nutrients that it needs to function. So at the end of the day, the best diet for someone who is living with cancer and treatments is to focus on the nutrition that, you know, like what you can eat, right? Making the most out of every bite. And, you know, like if you can't tolerate something, then we'll find something else that will work for you.
Thank you. And I see some hungry faces. I want to make sure we all get some lunch. But are there any other questions for our panelists? And remember, we have another panel coming up in the afternoon. Amazing. So with that, I'd like to thank all our panelists. So Dr. Schultz-Kwak, Dr. Carol Nissan, Dr. Carmen Chung, Dr. Alamova, Dr. Mosko, Dr. Trevor, Pugh, Samantha, and Teresa. Thank you so much, and we'll go for lunch now.